Hi, everyone, and thank you for joining me today to discuss some proposed ideas for nutrition intervention in the congestive heart failure population of Southern Maine. So before we jump into today's presentation, I just wanted to take a moment to introduce myself in order to provide some background as to why I'm passionate about implementing nutrition intervention for the congestive heart failure population of Maine. My name is Caitlin Gass. I am currently a graduate candidate in the Masters of Applied Nutrition program at the University of New England with an expected graduation of December 2020. Prior to that, I did complete a Bachelor's of Science in Food Science and Human Nutrition from the University of Maine in 2014. In the past 6 years, I have been employed at the Northern Light Mercy Hospital in the clinical nutrition department, and my full-time position includes a group benefits training position at Sun Life Financial, which is a group insurance company here in Scarborough, Maine. Through both of my positions with dealing with the clinical nutrition department, disability training, and an overall insight for the human population, I've gained a passion for utilizing nutrition as a lifestyle modification tool to prevent, manage, and stabilize chronic disease. In the case of congestive heart failure, there is no cure, so the main goal is to stabilize and manage the symptoms, which can very well be done through a partnership between medication management and nutrition intervention. Today's session will be brief but poignant. We'll plan to discuss the basics of what congestive heart failure are, what the target population that is proposed for nutrition intervention in Maine is intended, why this population requires these interventions, and finally we'll discuss two proposed nutrition intervention programs that could be utilized to close some gaps in treatment and disease management for the CHF population. So in general, CHF, congestive heart failure, is a chronic and progressive condition or disease. It affects the pumping power of the heart and, in short, diminishes that pumping power. The stage of heart failure that is CHF is where fluid has built up around the heart, causing further ineffective pumping. The ventricles of the heart cannot pump enough blood to the body, and that blood and fluid then backs up into the body, causing a collection in areas such as the lungs, abdomen, liver, and lower body that then leads to those symptoms of swelling, edema, fatigue, weight gain, shortness of breath, chest pain, and irregular heartbeat, and an overall lack of stamina. At the national level, many people are affected by CHF. Currently, 5 million Americans are suffering with CHF, and there are approximately 550,000 new cases diagnosed per year. CHF is present in 2% of individuals aged 40 to 49 and 5% of individuals aged 60 to 69. Over the age of 65, the CHF occurrence grows to nearly 10 per 1,000 individuals. The generalized causes of CHF that have been found are hypertension, that high blood pressure, pre-existing coronary artery disease, heart valve conditions, diabetes, thyroid disease, obesity, either due to genetics or improper diet and lack of exercise, some generalized infections, and some allergic reactions. After examining CHF population at the national level, I decided it was important to take a look at my home state of Maine. The programs in place for CHF treatment and care are very well developed in the state of Maine, but unfortunately there is a lack of formal nutrition care follow-up in place once a patient is actually discharged from the inpatient setting. Southern Maine itself is made up of two of the most populated counties in the state, Cumberland County and York County. The national statistics, as we just examined for CHF diagnosis, show that 2% of individuals are affected by CHF beginning at the age of 40, and that incidence only increases from there, which is why the target population selected for the proposed nutrition interventions in this program is adults over the age of 40 living in the Southern Maine area that have been diagnosed with CHF. These individuals will have at least one prior hospitalization with a primary diagnosis of congestive heart failure. Unfortunately, the present published literature related to CHF cases in Maine is very limited. It does call for some additional research and documentation, as the last community needs assessment conducted for this population was back in 2012 with primary data from 2009. There are two main CHF programs in the Southern Maine area. One is Maine Health Cardiovascular Care, and one is Northern Light Cardiology. The Maine Health Cardiovascular Care runs through Maine Medical Center, and the Northern Light Cardiology runs through Northern Light Mercy Hospital in Portland, Maine. There is a general need for nutrition follow-up care in the CHF population upon discharge from the hospital. The present inpatient CHF care programs in Maine, both of those stated previously, are following the American Heart Association guidelines to a T, with great protocol and order sets involved. According to the CHF Transitional Care Coordinator at Northern Light Mercy Hospital, Lisa Kasher, the primary population that she is seeing in Maine with CHF are Medicare patients. Upon discharge, healthcare providers are able to follow up on CHF patients to ensure they understand their diagnosis and treatment plan, and to implement a CHF diet that involves decreased sodium, fluid management, and a heart-healthy diet. Making some of these changes to the diet of a CHF patient can really alleviate many symptoms, cause stabilization of the disease, and overall disease management to prolong life. Unfortunately, many CHF patients lack that stamina to, number one, obtain their own groceries, number two, prepare their own food, and in many cases, individuals lack an overall support system of friends and family to assist them with these items. The first intervention that is proposed for this CHF group upon discharge from the hospital is the medically tailored meal delivery program. CHF diet adherence can be very difficult for those with complex medical conditions and comorbidities such as advanced liver disease, kidney disease, obesity on top of their CHF diagnosis. CHF itself is actually classified as one of the key diagnoses identified in the Hospital Readmission Reduction Program, or the HRRP, that was implemented under the Affordable Care Act under President Obama in 2012. One of the main programs that was identified to remedy hospital readmission for the CHF population was a medically tailored meal program. And it has been identified as an option to reduce those hospital readmissions when medical diets are actually prescribed by a physician or dietitian, just as medication would be. This would include the likelihood that with provisional meals, it would allow for a greater likelihood of CHF patients to be discharged to their home rather than to a long-term care facility or rehab. The program would predominantly focus on delivery of 3 medically tailored meals per day with dietitian oversight to ensure sodium is monitored and a heart-healthy diet is overall maintained. There is potential for funding for this program through Medicare or Medicare Advantage, as this is how this program has been funded in other urban areas of the United States, with the closest being Boston, Massachusetts. There is a program in Southern Maine already acting in very similar ways called the Southern Maine Agency on Aging, who manages the Southern Maine Meals on Wheels program. They are already delivering 5 meals per day to the elderly low-income population in Southern Maine. They have direct dietitian oversight, but this program is only intended for the homebound population. Under this program, the medically tailored meals, in conjunction with the Southern Maine Agency on Aging, would be intended for all CHF patients discharged from the hospital in Southern Maine that are unable to procure their own food and prepare their own meals due to their disease progression and lack of stamina. In conjunction with that program with SMAA, we would move to enact a program under the Hannaford Supermarket Dietitians. Currently, the Transitional Care Coordinator for the CHF program at Northern Light Mercy Hospital is making use of the dietitians through Hannaford Supermarkets, which is the largest supermarket chain in the state of Maine, for follow-up care for discharged CHF patients. The program would aim for a referral process to Hannaford dietitians that would be able to provide nutritional education, information, recipes, shopping lists, and even actually be able to travel to an individual's home to assist in shopping. There is no current present formal program design for this process, and it's kind of at an ad hoc process at this time. So we would aim for a more formal referral process and partnership between the hospitals and the Hannaford dietitians. Presently, 40 to 80% of what is provided to a patient during an inpatient education is forgotten immediately, which is why we need this follow-up care to ensure that diet education is being adhered to. Implementation of this formal referral process is warranted for CHF patients upon discharge. It'll allow them to feel more supported in their grocery shopping and meal preparation in order to adhere to possibly a new diet that they have not come in contact with before. There would be strict adherence to HIPAA guidelines, as information would be shared between providers and the Hannaford dietitian. And there would be some pretty stringent consults to determine what the patient's needs in the actual outpatient setting with the Hannaford dietitian would be. It would be a pilot program, again, in partnership between Hannaford Supermarkets, Maine Medical Center, and Northern Light Mercy Hospital to provide that nutrition, education, and support upon discharge for those patients that are still able to shop for themselves, but feel they need a little additional support in order to make the correct decisions. The present research in general promotes a comprehensive discharge plan for CHF patients in order to reduce hospital readmissions for CHF and improve quality of life. Through lifestyle modification, following a low-sodium diet and a heart-healthy diet, it will be easier for CHF patients to stabilize and manage their disease through this lifestyle modification. With the two programs, medically tailored meals would allow for those individuals with CHF that are unable to shop or prepare meals due to a lack of stamina, income, or age. They would be able to be provided those meals to their home. And for the other half of CHF patients in their population, it would allow for them to still do their own shopping and meal preparation with support on both the education, shopping, and preparation level. So I just want to thank you all for joining me to go over the proposed interventions for the CHF population in Southern Maine, and I hope you all have a great rest of your day.